Welcome back to the American College of Surgeons Bulletin Brief from the Front Lines, Surgeons' Voices. With me today is Dr. Ajita Prabhu, who is the Quality Officer for the Digestive Disease Institute at Cleveland Clinic Foundation in Ohio, where she's also an Associate Professor of Surgery. Ajita is the Treasurer of the American Hernia Association and is an active hernia researcher. Welcome, Dr. Prabhu.
Thanks for having me.
Appreciate you taking the time to be with us. The impetus for the interview today was what I thought was a very well-designed and expertly analyzed study of robotic versus laparoscopic ventral hernia repair with intraperitoneal mesh that we published in JAMA Surgery. So I'd like to chat with you about that article, if we might. Starting out with, what was the impetus for this particular study?
Sure. I think actually, funny enough, when I started utilizing the robot for hernia surgery, initially, this was probably around 2014, 2015 timeframe. I think I had envisioned going right to complex abdominal wall reconstruction on the robot because I thought, the technology was just really ripe for that type of intervention. And then as soon as I started, in order to get better with my skill set, I started doing these robotic intraperitoneal onlay mesh repairs, so robotic IPOMs, just to get the skill set of how to suture robotically. And after doing a few, I started to realize that operation was very elegant. The way that I could suture the edges of the mesh to the abdominal wall and the way it laid nice and flat after the operation, I thought was really impressive. And then, I started to think about what the most common things are that surgeons in the United States are doing. And so for small to medium-sized hernias, I think, a standard type of repair would be a laparoscopic IPOM repair with a tacker to put the mesh in place. And so I started to wonder, when I'm suturing this mesh and it lays nice and flat like this, and it looks so elegant and flat against the abdominal wall, doesn't that hurt less than using a tacker to position the mesh in place? So that was where I got the idea to do this study. And that's what kind of started the whole question for it.
Great. Thanks very much for the background. And then if you could please share with us your study design.
Sure. So, I think it's really important, as we all know, when we're designing a prospective study, we want to reach an outcome that's clinically impactful. To me, the outcome wasn't going to be length of stay, primarily because, at my setting and likely at yours, there are a lot of patients that come from out of town, out of state, whatever it might be. And I think length of stay can be a really variable type of outcome to look at. So we were looking at specifically the clinical outcome of pain. And as a team, when we were trying to decide what to study, we thought, what is the minimal clinically important difference that we would like to see in pain postoperatively if the robot does indeed have an advantage over laparoscopy. So we set our outcome at a 30% difference in the numeric rating scale, which is the NRS 11, at the first postoperative day. Now, as we all know, these patients are typically in the hospital either just for the day and they go home the same day, or overnight. It's kind of a wash. So we're not talking about great amounts of pain. However, what we thought was important is that if the patients are having a significantly less amount of pain with one approach over another, then perhaps that may also translate to less opioid use, quicker recovery, that type of thing. And then, of course, over time, other things we wanted to know were hernia-specific quality of life, operative time, wound morbidity, and of course, recurrence. And then we also looked at length of stay and cost.
Well, it sounds like you certainly hit all of the key variables which might influence future behavior based upon the outcome of the study. So the next question is obviously, what were the results? How many patients did you enroll, and what did you find in these various variables which you analyzed?
So we ultimately were pleased to enroll 75 patients in the trial that completed their repair. So 36 of those were laparoscopic, 39 of them were robotic. And they were similar groups, as far as their baseline demographics went. And what we found was that there were no significant differences in the NRS 11 score preoperatively or on postoperative days 0, 1, 7, or 30. And, the median NRS 11 scores on the first postoperative day were the same. So specifically, that was our finding for our primary outcome.
Okay. Couple of other things you mentioned, I think, hospital length, although it sounded more secondary than primary. And how did
Mhm.
that pan out?
Hospital length of stay. Actually, we didn't find a difference in any of the other outcomes, including quality of life scores, length of stay, or complication rates between the two groups.
How many surgeons participated in the trial and how many sites?
There were two surgeons at one site, and this was all at main campus Cleveland Clinic. So myself and my partner, Dr. Clayton Petro.
And one of the questions that a lot of folks would ask when a trial doesn't show a favor in one direction or the other, well, what was the prior experience of the participating surgeons in each of the technologies? So both laparoscopic and robotic for you and for your partner.
So I'm glad that you brought this up. This certainly has been a notable point in our study, which is that, we are both fellowship trained abdominal wall reconstruction surgeons. Myself, I am in my 10th year of practice now, so I've been doing laparoscopy for a fair amount of time, including advanced cases. And also, as I mentioned, I started on the robot around 2015, and so had a pretty robust experience with robotic IPOM. Dr. Petro is a little bit behind me on his learning curve, so I would say he's in the newer part of that curve. And we did actually do a kind of post hoc analysis of our operative times as they compare to each other, just to see, is there some particular difference where one of us with more experience is outstripping the performance of the other, and we did not find that to be true. I do want to also add, I think it's really important to note the context of this, which is that when we look at hernia repair across the United States, one of the most common procedures performed robotically across the United States is robotic ventral hernia repair using the technique that I mentioned. It is considered to be truly one of the quote unquote starter type cases when surgeons are starting on the robot. So to me, I think actually the experience piece of it is important. And I think it's important to note that we were at different points on our learning curves, and yet our performance ended up being similar.
Thanks a lot. That's an interesting point. One other variable, which pretty much everyone asking questions at any panel discussion when it entails surgical technology, is cost. What did you find between the two groups relative to cost?
So we did note that, and we reported cost ratio because, of course, we can't report the exact numbers due to proprietary reasons. But the total cost ratio was noted to be 1.13 versus 0.97%, and that was statistically significantly different. And that was actually mostly driven. We did look at disposables and operating room time. Disposables, reusables, operating room time. And what we saw was that the cost was driven primarily by operating room time. So there was a fair amount of extra time added by using the robotic platform for both of us. And that time difference was about 150 minutes versus 100 minutes.
Was that time related to performing the procedure, or was docking included in that time?
The entire operation was included in that time, so that did include the docking time. Although these procedures were performed, the majority of that time is likely attributable to the operation itself because we're pretty facile with docking. I don't think that was a major contributor to that for us.
Constant OR teams in the operating room with you?
They're all robotically trained teams. It may not be the same personnel, but they're all facile in the robot. And I should add too, for the technical aspect of it, for a laparoscopic procedure, we were tacking the mesh in place, and we also placed transfascial sutures. So that was the method for mesh fixation laparoscopically, where robotically we sutured the perimeter of the mesh to the abdominal wall. And I think it's worth pointing out that transfascial sutures are pretty quick to place, and laparoscopic tackers are pretty efficient to use. So I'm not 100% sure that even once a surgeon overcomes the learning curve on the robot, that we could ever expect suturing the mesh to be as fast as tacking it.
Okay, that's certainly an excellent point. And then, of course, based upon what you found, what have you concluded that should be our future behavior relative to fixing these hernias?
Well, there are a few things that I think that are interesting. So first of all, I think there's a big focus on the cost differential because when we look at our study, that's where the p-value is. And I think it's important to consider that finding in its broad context. So when we consider the fact that that cost was almost entirely driven by the operating room time or the time it took us to perform the procedure, I would kind of come back at that and say, all right, well, if we realized our minimally important clinical difference of pain with that time, then perhaps that time spent would be worth it and perhaps the cost would be offset by other clinical benefits or advantages. We did not see that here. However, the other thing that we can say is that these operations were performed likely to the same level of clinical equivalence as the laparoscopic ones in terms of short-term outcomes. We don't have our 1-year outcomes reported yet, and that'll be coming. So what I could say is I do think that this operation, at least in the short term, is safe. I think it's effective. I think it's a perfectly fine operation to use as a initial start if somebody's trying to learn how to use the robotic platform. So I don't think that there's necessarily any detractor from using it. I think that surgeons just need to understand that this is a small piece of the puzzle. There is a similar prospective randomized control trial by Mike Liang's group from Texas that actually shows similar findings to ours, but we're still early in this process. So I do hope that other studies will be coming out so that we can get a bigger, broader clinical picture as we move along. But until then, I would just say, right now for my practice, this probably doesn't add a lot of great value. However, I know that patients will likely at least do as well if I use a robot.
So that would lead to my last question, which is, given your concluding statement just now, do you envision that with additional robotic platforms and or modifications to the platform you used, that the conclusion might change if you redo this study in the future?
I think that we should not paint all of the technology with too broad of a brush. I think that the onus is on us as surgeons and clinicians to really get a good critical appraisal of each technology as it comes along. I think that the modalities of use might be vastly different as these robotic platforms evolve over time. I do think that competition will also drive innovation. I think that it will drive costs down. I think that this is kind of the first dipping our toe in the water of truly evaluating the technology for what it can do. And I think we have a long way to go. And I actually hope to see a huge benefit to the use of robotic platforms in general surgery, particularly in hernia surgery as we move forward.
Well, thanks very much for your time and for your insights. Congratulations on having organized, executed, and expertly analyzed a very nice study. Appreciate your time today.
Thanks so much for having me.